Good afternoon.
Good afternoon.
The quote that you see on the screen right now is from Thomas Jefferson. It comes from the foreword of a book, a very interesting book. It's called The Invention of Air. It's by Stephen Johnson. And it follows the life of Joseph Priestley, the guy that we say discovered oxygen. Now, if you read The Invention of Air, you'll find out that even though we say Priestley discovered oxygen in 1775, a guy by the name of Carl Scheele had actually found those properties in 1771 or 1772. But the fact of the matter is, he never shared his information with anybody until like 1777. But the fact of the matter, when you're talking about Priestley, he was a different guy. As the quote on the screen shows right now, is talk about sharing information. The sharing of information, which is very important. Important information is very important, and getting it out to different people is quite important. Dr. Glenn mentioned the fact that hyperbaric medicine is probably not used enough. So I take it upon myself, as any opportunity that I can get, to speak about hyperbaric medicine. I try to share my information that I have with you, enough information to make you comfortable enough to have a conversation with somebody else that may need the benefits of hyperbaric medicine. So what I'm going to do is walk through a process, sharing the information that I know, how it works, why it works, and what we use it for. So at the end of this conference, at the end of this meeting, this talk itself, you will be comfortable enough to share this information with somebody, maybe a family member, maybe a neighbor, maybe a friend, that can benefit from this service. Now, hyperbarics is not taught in medical school. You don't see that much often. A lot of people who use hyperbarics are only the people that have been exposed to hyperbarics. So again, the fact that I'm here sharing this information with you, you could be a conduit. You could be someone that could help someone else with hyperbaric medicine, as far as that's concerned. So following with the idea of what Jefferson's talking about is the sharing of ideas that we're trying to present today. So I'm Keith Knight. I manage the post-op trauma clinics at UAB, along with the hyperbarics and wound care program that we have over there. I started that program in 2012. We started in 2012. We've been strong, built a strong program over the past few years. I also previously started a program at Caraway Hospital, started a program at Brookwood Hospital, and started a program at Princeton Hospital. I've been in the business myself for a little over 40 years, and I was actually in the Air Force when I learned hyperbaric medicine. I was in aerospace physiology, and we trained pilots about the mechanical effects on their body when they go to altitude. And dealing with the mechanical effects of the body and going to altitude, we had what they call hypobaric chambers, which would simulate taking them up to altitude. And conversely, we had hyperbaric chambers, which would simulate taking them down to depth and diving. And we'll talk about the difference in those two and why we use them in a couple of minutes. So what hyperbarics is, it's the full exposure of your whole body inside of these chambers, breathing 100% oxygen. Now, I make that statement because of the fact there are products on the market where they're not using 100% oxygen, or they're not even putting your full body into to be exposed to the oxygen environment. And I'll show you a couple of examples of those also. But what we want to know is the fact that when you're talking about hyperbaric oxygen, it's the full body that has to be exposed to 100% oxygen in an environment. Now, I'm a little bit of a reluctant philosopher, a weekend scientist, if you will. So I came up with my own formula for what I think hyperbarics is. So for me, hyperbarics is simple physics, it's simple physiology, and we'll walk through that process also. So as we know, at 1 atmosphere, there's 760 millimeters of mercury of gas available. 21% oxygen, 79% nitrogen. What we're able to do in a hyperbaric environment is we can increase atmospheres. So every time we increase an atmosphere, there's another 760 millimeters of mercury of gas available. Since that gas is oxygen that we're using in the chamber, there's another 760 millimeters of mercury of oxygen available. We can get up to 2,280 millimeters of mercury of oxygen in a hyperbaric chamber. Get that exposure to any patient that goes inside the chamber. We're going to talk about a couple of gas laws and how they affect the process in hyperbaric medicine. We're going to talk about Henry's law, Boyle's law, Charles' law, and the Gay-Lussac. These are the four major mechanisms of action for hyperbarics. How does it work? Hyperoxygenation, vasoconstriction, microbiological effect, and bubble reduction. Henry's law. The amount of gas that dissolves into a liquid is directly proportional to the amount of gas above the liquid. What we know in a hyperbaric environment, let's take it on the surface. If you're breathing 100% oxygen on the surface, once your hemoglobin is saturated, there's no more uptake of oxygen in the body, no matter how long you're breathing that oxygen. If we put you inside of a hyperbaric chamber, not only can we saturate your hemoglobin, we saturate your plasma also. So the amount of gas that's dissolved is directly proportional to the amount of gas above. So if we take you down to 3 atmospheres, 2,280 millimeters of mercury of oxygen available, we can dissolve a lot more oxygen into your blood and into your plasma. That's where the true benefit comes into play, following along with Henry's law. So what happens with hyperoxygenation? It extends the oxygen diffusion distance. What we know about a lot of wounds, particularly like non-healing diabetic feet and things of that nature, there's very little circulation. They don't get a whole lot of blood flow. They get some, but not a lot. What we're doing with hyperbarics is we're increasing the amount of oxygen that's available, so the body has that oxygen to draw from. A lot of people, even in the field of hyperbaric medicine, will tell you that we help speed up healing. We don't speed up healing. The body only needs 21% to do its own functional healing functions. That's when there's a problem that the body needs support, and that's where hyperbarics comes in, when the body can't do it for itself. So we've been very fortunate with that process. So extending the diffusion distance, getting more oxygen to different areas of the body, improving the function of osteoblasts, osteoclasts. We're talking about bone growth. We're talking about tissue growth. We're talking about all cell growth. All those are predicated on having enough oxygen. If we don't have a problem, we get cuts and scrapes on our bodies all the time. And this process goes into effect with just 21% oxygen. But some people have deficits and have issues that they don't get enough oxygen to those areas. That's where hyperbarics can come into play. And we'll talk about that a little bit more in depth also. Demarcation, viable from non-viable tissue. I'll talk specifically about that, about some of the surgical cases that we've had also. Hyperoxygenation, again, the O2 gradient hastens gas exchange. We know for a fact in simple physics, gases go from a high pressure to a low pressure and just above the blood. And when you're forcing this oxygen into the blood system, and you have to be breathing the oxygen in, and you're forcing this oxygen into the blood system, it's going to saturate your plasma. It's going to saturate your tissues for the time frame that you're in the hyperbaric environment. It drives O2 through barriers and a reduction in tissue blood flow, which is a big factor, the reduction in tissue blood flow. So that would be vasoconstriction. Hyperoxia itself causes a vasoconstricting effect. And you would think about, well, why do we want to vasoconstrict? You just told me that, people have a difficulty getting oxygen to those different areas of the body. But what we're able to do with that, we can cut back on swelling and edema. And we all know those are barriers to any type of healing when you have swelling and edema. We're actually cutting back on the blood flow, but blood that is available is very highly oxygenated, far better than it has been in the past. So even with the vasoconstriction, we're able to assist the body with its normal healing process. And I mentioned normal healing process. We just make the oxygen available, and the body does its normal process because it is available to it. We see very good cases of this with cerebral blood flow. It can cut back 30%. Again, we know with problems with head injuries and things of that nature, a lot of swelling, a lot of edema. We're able to cut back on that blood flow with that vasoconstriction, plus highly oxygenate that tissue, keep the tissue viable during that time frame. With burns, a reduction of fluids and electrolyte loss, big factors when it comes to healing, big factors. In crush injuries, again, swelling and edema are some of the barriers that we have to that type of healing. Just being in the hyperbaric environment, we can use that vasoconstriction to help benefit those patients that come with those types of cases. So there's a microbiological effect. Hyperbarics is bacteriostatic, bactericidal to anaerobic organisms. Without damaging the host tissue, it still fights against those anaerobic organisms. And is lethal for most strictly anaerobic organisms, particularly things like gas gangrene, necrotizing fasciitis. We see a lot of success with those types of cases in the hyperbaric environment. So Boyle's law. Boyle's law tells us if we increase pressure, we decrease the volume of a gas. This is what we use. This is another reason that we use the hyperbaric chamber, decreasing the volume of a gas. Reasons why? A scuba diver, you get decompression sickness. You have gas bubbles. You come up from the depth too fast and the gas bubbles escape and they start causing blockage. Could be just pain, could be neurological effects. We put you in the hyperbaric chamber, we increase pressure, we decrease the size of that gas bubble in any chamber. There are chambers out there that can go to 100 to 165 feet, what they call a multiplace chamber. They can decrease that size of that gas bubble quite significantly in a very short time. And I'll show you some examples of that also. But that's how Boyle's law works with us in the hyperbaric environment. Some of the issues, not only diving injuries, iatrogenic. What if you introduce gas in surgery or something like that? We see those cases a lot. We're able to get those patients in a hyperbaric chamber, decrease the size of the gas bubble so it doesn't cause any permanent damage if we get them quickly enough. And that's another key factor, that we get them quickly enough. Looking at the screen, you can see the size of the gas bubble at 1 atmosphere. It's 100% diameter there. When you're at 165 C, it's relatively 55% at 55%. That's why when you see active scuba divers, they typically go to a facility where they have a multiplace chamber, particularly if they have neurological effects from diving injuries. They put them in the chamber, they can get down to 165 feet in less than 10 minutes. It could be a pretty rapid descent, depending on the fact that they can clear their ears to get down to depth. But you have an immediate relief of the size of the gas bubble, immediate relief of the size of the gas bubble, which could cause future damage. So that's one of the key things you want to do. That's why scuba divers get to those facilities as quickly as possible when they recognize the fact that they have decompression sickness. So some of the secondary mechanisms of action for hyperbarics: fibroblast proliferation, neovascularization, and osteogenesis. As I mentioned earlier, new tissue growth, new bone growth, new vascular growth, things of that nature. We'll talk about some of the issues that we have, some of the diagnoses that we treat, and how these actually come into play for the secondary mechanisms of action. Accepted indications. For the acute and emergent situations that we do, one of the biggest ones is carbon monoxide poisoning, cyanide. Why carbon monoxide poisoning? We know in carbon monoxide poisoning, it binds to the hemoglobin quite readily, more readily than oxygen does. What we're able to do in the hyperbaric environment, remember, we can get you down to 3 atmospheres, 2,280 millimeters of mercury of oxygen available. While you're breathing that oxygen in, we can displace some of that carbon monoxide in the body just by giving dissolved oxygen into the blood system. That's a huge benefit, huge benefit. And again, this is time factor. The sooner we get those patients, the better results we get with those type of patients also. We get plenty of cases that we have family members in the wintertime using charcoal and things of that nature to heat the homes or cook food with like that. And we get family members, a full family of 2, 3, 4 people that come in with carbon monoxide poisoning. But we're able to put them in the chamber and assist them with their problem they're having by just introducing that oxygen under pressure. Cerebral arterial gas embolism, as I mentioned, some gas can get released during surgery. Again, just working simply from Boyle's law, put them inside the chamber, increase the pressure, decrease the volume of the gas. It's quite that simple. Decompression sickness from scuba divers, exceptional blood loss anemia. What we've done is supersaturated your blood, hemoglobin, and plasma. Some patients, for religious reasons, do not receive blood. We can assist those patients in a hyperbaric environment by the dissolved oxygen that we have into the plasma and into the hemoglobin. necrotizing soft tissue infection, necrotizing fasciitis. It's the anaerobic, the microbiological effect I talked about. The bacterial static is bactericidal. That high oxygenation just fights against those anaerobic organisms, and it does it in a complete fashion. When we used to work at Caraway Hospital, it's now defunct, we used to go to the emergency room with the surgeons, and two things that we would notice. One was the demarcation. When the surgeons went in and opened the patients up, for the damaged tissue that they had, you could viably see the difference in the bad tissue and the good tissue after hyperbaric treatment. That tissue would be just beefy red where was hyperoxygenated. And the other tissue that was damaged was dark, and it was very easy for the physician to go in and dissect that bad tissue out, get rid of that bad tissue, and save the viable tissue also. We used to see this quite often with these types of cases at Caraway Hospital. We were very beneficial. The surgeons was very happy with the fact that they were able to see that demarcation too, so they would not waste any good tissue in the aspect of trying to help the patient at the same time. Gas gangrene, again fighting anaerobes. Crush injuries. What we know about crush injury compartment syndrome, one of the biggest factors, key factors that happen there is swelling and edema. Swelling and edema. Vasoconstrictive fact that takes place from hyperoxia automatically in the hyperbaric environment benefits these patients when they come to our department. We get a lot of patients from surgery that they're working on, and we work with surgery. We don't replace any surgeries at all, but we are working hand in hand with these guys, going back and forth to surgery and coming back to the hyperbaric chamber. Acute reattachment and suturing of limbs. We've been very successful with a lot of those types of cases. Again, these things are time sensitive, getting patients into our environment, and getting them inside the chamber, and getting the treatment started. Acute peripheral ischemia, that's just getting oxygen to those different areas of the body where oxygen has been hypoxic for some time. Thermal burns, again, cutting back on swelling and edema and fluid loss. The brown recluse spider bite. As you know, the brown recluse spider bite, it puts a venom, there's anaerobic venom into your system. I don't know if you guys ever seen real cases of brown recluse spider bite. They can be horrific, actually. But we've had them over the years, and patients will come to us. What happens with the brown recluse spider bite, once it puts the venom in, it starts eating away like Pac-Man. It starts going around and going around, and it just spreads and spreads and spreads. What we're able to do with the hyperbaric environment is, when we put them in the chamber, increase the volume, we got more oxygen into that area than normally would be there, then that venom cannot spread anymore. Because of the oxygen, it cannot survive in a highly oxygenated environment. So the anaerobes cannot spread any further. Now, we can't reverse anything that has happened that's necrotic or dead or anything like that, but we can limit the effects of it. And again, time sensitive, getting into a chamber. How many people know that if a brown recluse spider bites you, you can go in a hyperbaric chamber and save skin and time and things of that nature? That's why we have conversations about that. These items on the chronic wound is probably what keeps hyperbarics in business today. Non-healing diabetic feet, enhancement of healing and selected problem wounds, just typical surgical wounds that don't heal up on their own. Most wounds, they go through a process, and they've done all they can to try to heal up, and sometimes they just don't heal. They need a boost. That's all it is, just a simple boost. We can put them in a hyperbaric environment, increase the amount of oxygen, and we see that activity start all over again. You got osteoclasts, osteoblasts, the fibroblast stuff, all that activity starts happening again because of the introduction of high content of oxygen. And we know that oxygen is the catalyst to any type of healing that takes place, whether it's going to be bone, skin, or tissue. Compromised skin grafts and flaps, we get those all day, every day. We do a lot of breast injuries, breast reconstructions. That tissue is fine. That tissue has very little blood flow going to those areas. We're able to help assist those plastic surgeons in making sure that the hard work that they've done in the reconstruction don't go to waste, because tissue can get damaged quite easily in that type of environment. We treat those probably we probably get 6 to 8 cases a month with breast injuries and things of that nature. Different plastic surgeons from around town send all their patients to us because of the benefits that we can provide. Radiation necrosis, soft tissue and bone. What we know about radiation is a necessary evil in a sense, I would say. We need it to fight against the cancerous cells and things of that nature, but it also damages good cells and good tissue. And those tissues lie dormant with not enough oxygen. Now, we can put them in a hyperbaric chamber. It's not going to happen overnight. These type of cases, when you're trying to get neovascularization, things of that nature, it takes about 40 to 60 treatments before you start seeing adamant results with that situation. But we know that. We've seen the results. We've seen what we do for proctitis. We've seen what we can do for cystitis. We've had very good rates of healing those type of patients and type of conditions in the hyperbaric environment. And basically what it boils down to is rolling into a hyperbaric chamber and breathing. As simple as that. That's all we have to do. Increase the amount of oxygen. The body's going to do its normal process to try to heal itself. Refractory osteomyelitis. We get tons of these cases. We haven't had as many as we had in the 90s and the early 2000s because of the fact that antibiotic process is a little bit better what the orthopedics are using at this point in time. So they're cutting back on some of the refractory osteomyelitis that we used to see in the 80s and the 90s. But we still do a lot of those cases also. So here are the benefits. Again, we dissolve oxygen into the blood plasma. Simple process, simple physics, simple physiology. You put them in the hyperbaric chamber. You increase the pressure, you breathe 100% oxygen, you get the benefits. We increase the concentration to the hypoxic areas, and that's what we find out a lot of times with a lot of these non-healing wounds. The areas are just hypoxic. They just haven't had enough oxygen in there. If we can get the oxygen there, again, the body does its normal healing process. We remove the barrier that's stopping it, the lack of oxygen. We provide that oxygen there, the body does its normal process, again, to heal itself. Reduces edema by vasoconstriction, and again, as I said, hyperoxia itself causes that vasoconstriction. And it promotes white blood cells bacterial activity, and that's how we fight those anaerobes. That's how we fight those anaerobic organisms, because of the fact that it supports that. So, with any good benefits, you got side effects, all right? So the side effects that you have in a hyperbaric environment is ear and sinus barotrauma. Any scuba divers, anybody ever done any diving? If you haven't done any diving, you're probably going to end up in an airplane. You feel the pressure on your ears when you go in the airplane, go up or come down. We get that same type of sensation inside of a hyperbaric chamber. So we have to make sure patients are aware that they can clear their ears. They use different techniques. Sometimes they sip on water. Sometimes they can pinch a nose and blow. Sometimes they can swallow. It's just different people, different benefit. They benefit different ways. But if you don't clear your ears, it will hurt like heck, trust me. And you can actually rupture your eardrums also. But it's a simple process, it's a simple fix. Just find out what mechanism works for you. Most of our patients pinch their nose and swallow water or something like that, and it pops their ears. So it's a simple process, but if you don't fix it, it can hurt pretty badly. Sometimes there's visual changes, a little bit of myopia. If any patients do a long-term hyperbaric treatment, which sometimes they see this effect from getting too much oxygen, but it reverses back once they get out of the hyperbaric environment. As we say, oxygen is considered a drug in this environment, and the hyperbaric environment is considered a drug. And as we know, too little of any type of drug can be non-therapeutic. Too much can be toxic. Oxygen follows that same category. Too much can be toxic. You can have grand mal seizures if you get too much oxygen. Some patients, they differ. You don't know which patients are going to have a problem with oxygen and which ones don't. We use a standard protocol for probably 85% of the treatments that we do. There's a standard protocol we go to 2.4 atmospheres for 90 minutes. They get 90 minutes of oxygen at 2.4 atmospheres. That's a prescription. That's just like the doc wrote a prescription, and they get that prescription on a daily basis. Our patients come 5 days a week, and typically an average patient treatment, if it's not an emergency case, it's going to last anywhere from 30 to 40 treatments. The emergency cases last anywhere from 2 to 10. Pulmonary toxicity. We have patients that we can treat on the ventilator. There are ventilators that can be used connected to a hyperbaric chamber. If you got a patient on the floor on the ventilator all day, you bring them to the hyperbaric environment, you're going to give them all this increased oxygen. You have to be aware of that. You have to be aware of that pulmonary toxicity. You have to know what their load has been, for the time they was upstairs. So you have to make sure that you're putting the patient in there, you're safely putting the patient inside the chamber. We have to keep up with UPTDs just like, respiratory would do if we're treating patients with these types of diagnoses. So those are the side effects, the major side effects that you could have. And other boredom. A lot of people get bored just being inside the hyperbaric chamber for 2 hours, roughly. Charles' law, we talk about if you increase pressure, the temperature increases. That's one of the effects that patients feel. Even though we're filling the chamber with 100% oxygen, because we're compressing inside that environment, it gets quite warm. It can get up to about 73, 74 degrees inside that little tight environment. And some patients, they start panicking because of that. But we have to educate them prior to it, letting them know that it's going to happen. Now that's just on the compression that you're going to get that heat. Once you get to your treatment depth, which is 2.4 atmospheres or 45 feet of seawater, the chamber is going to level out. The air is going to start flowing by. It's going to cool down to about 70 degrees, and there's going to be a constant flow of oxygen passing by the patient. And it actually gets kind of cool at that point. So typically we send patients down in the chamber, even though it's going to get hot initially, we send blankets down with them also. So they use a blanket, to cover up once they get settled at 45 feet of seawater. So inversely, when we bring them back up to surface, we pull the oxygen out of the chamber, they get cool. And that's where the blanket comes into play also again, because it can get pretty cool. If we're treating a patient inside of a multi-place chamber and going down to 165 feet, it would get extremely hot. It'd get extremely hot. But on the way back up, it'll get extremely cold also because of the extreme depth that we're using at that point. This is a typical layout for a hyperbaric environment. 3 chambers, 2, 3, 4, 5 chambers, depends on the facility that you're working with. These chambers are pretty simple. And the only mechanism that's taking place with these chambers is you're pumping air in, you're pumping oxygen in, and you're pumping oxygen out of the chamber itself. There is a connection where the patients inside the chamber can hear everything that you say. They can communicate back and forth with you. They can talk. We have a receiver on the outside where we can talk to the patients, but they have what's called a hot mic inside. They can talk to us at any time, let us know what's going on with them. Whenever the patients are inside these chambers, we are always sitting by the chamber at all times. We never put a patient inside the chamber and walk away from the chamber. Never walk away from them. This is an environment where the patient has no control, and you have to make them comfortable enough to go inside this chamber. They can miss out on actually being benefited from hyperbarics because of a fear factor of going inside the chamber. We do a lot of consoling prior to and education prior to going inside these chambers to educate the patient on the fact that we will be there for you at the same time, the whole time. If a patient would tell us that they want to come out the chamber, we take them out of the chamber. We don't talk them through it and say, just come on, you can do it. We don't do that. We have to have their confidence. They have to have our confidence. We know if we can get a patient through 1 or 2 treatments, we can get 40 treatments out of them. You can't get a patient under 1 treatment, you're not going to get anything past that. They have to have confidence that you're going to take care of them, you're going to support them. If they want to come out of the chamber, you're going to take them out of the chamber. Now, the only caveat about coming out of the chamber is it depends on how far along we into the chamber. If we're 5 minutes in, it's going to take a little less than 5 minutes to come back out. I can't automatically bring you out, just can't open the door because of the pressure that's on the door. So we have to explain to them, so I'm going to bring you up as quickly as I can. We continue to talk to them the whole process and get them out of the chamber. Gain their confidence. We tend to get most of our treatments in, and I'd say average about 30 to 40 treatments for most of the diagnoses that we do. This little slide right here, I think I may have yeah, I do. Okay. On this slide right here, this just kind of shows the idea of what happens inside the chamber itself. If you look on this slide, on this graph here, you have the oxygen tensions up to about 1,500 millimeters of mercury of oxygen. And down at the bottom, it's like going inside the hyperbaric chamber from start to finish. If you look, we got blood, muscle, and subcutaneous tissue on this side. So let's follow the trail on blood. When you get inside, first get inside the chamber, the blood goes up very quickly. You get high levels of blood oxygen when you go inside the chamber. It goes up very quickly. But if you can notice too, once you come out of the chamber, the blood levels come back down. If you look at muscle, it goes up a little bit slower, and it comes down a little bit slower. Subcutaneous tissue goes up even slower, goes in, saturation goes in even slower, and it comes back down to normal even slower. But here's the ideal. This is when we start the hyperbaric treatment. This is when we end the hyperbaric treatment. What's happening over here? You still got high tissue levels of oxygen. That's a key benefit. It's not just benefiting while you're sitting inside the chamber. It benefits up to a couple hours after you get outside the chamber. Now, the blood level may actually go up and come down right quickly, but the tissue and the muscle, they're going to hold on to some of that high concentration of oxygen, so you're still benefiting from the treatment that you had a couple hours ago. Now, this is important when we're talking about people that smoke. We have to tell smokers, people that smoke, they smoke. You know, you just have to work around that whole situation. And we try to tell them that there's a window of opportunity for your body to heal. And you can support that by not smoking within these time frames and things of that nature. So that's a significant factor that most of the patients that do smoke, you know, we have to kind of get them to not smoke prior to coming to treatment for at least for 30 minutes to an hour. We try. That's an effort. And at the same time, we show them this screen. We let them understand how you're still benefiting from this oxygen if you don't smoke when you step out of the chamber, you know, as soon as you get out of the chamber, because a lot of people do tend to do that. So we just have to educate them on that process. But this is just to show you the benefits of the oxygen. It's not just while you're inside the chamber. It continues on. Research, a lot of research on closed head injury, traumatic brain injury, cerebral palsy, stroke, near drowning, and myocardial infarction. Now, the biggest problem with the fact that all of these cases here, all these different type of diagnoses here, there's a lot of data, but there's limited data at the same time, because the N factor is quite small. Now, the DOD did some studies back maybe about 6 or 7 years ago on traumatic brain injuries, and they came up with some pretty good results. I think it was 2 weeks ago or something like that. I think Senator Tuberville's office got in touch with our UAB neurology guys asking questions about hyperbarics that our hyperbaric docs had to follow up on. And they're proposing a bill to have veterans get treated at the VAs for traumatic brain injuries, because there is data out there that supports that treatment of the damaged tissue that they have from brain injuries. So we're excited about that. We'll see where that goes. But over the years, it's just been a difficult thing to get consistent randomized blind studies on these type of cases. There's a lot of anecdotal cases, studies out there, but the randomized cases are not that many. But there is support to show that hyperbarics does benefit these types of diagnoses that we have here. So with a little bit of history to go back along with this, I mentioned that Priestley discovered oxygen in 1775. This is called a domicilium. This was a guy by the name of Henshaw in England. This is 1665. He has what is called a domicilium, and he got these giant bellows, and he would pump air into this environment. And he thought at this time that if he had more air, it would make you feel better. And he had kind of sold some people in this community about this whole idea. They would pay him to come and sit inside this domicilium, and they use these giant bellows to pump up the air, increase the pressure of air inside the chamber, inside this domicilium, and it was like therapeutic for people. So I think a lot of this had to do with they were just kind of duped. But the concept itself in 1665, even before oxygen was discovered, I thought was pretty ideal. So this is just a little bit of history of the chambers themselves. So this was 1935, I think, in Kansas City. A guy by the name of Cunningham, he had a huge chamber where he treated patients all the time. Got censored by the AMA because of the fact that he was making all these claims that he was healing people, he was solving flu and things of that nature, but he really didn't have any data to support what he was talking about. So they kind of censored him and put him out of business for that fact. But the idea that these multiplex chambers were around and that far back, 1935, it was pretty interesting. This was called the ball chamber. This chamber was about 6 stories high. Inside the chamber, there was different floors and different levels that were highly oxygenated. There would be a social thing that people would people with means, of well means, they would come and sit inside these chambers and breathe air. They would breathe air, increased pressure of air inside these chambers, and they at least said they felt better when they went through this environment. So we can't speak to that at this point, but that was their intention of that. As I mentioned earlier, we can do critical care in hyperbaric environment. I said that we can use ventilators inside the chamber. We can do critical care inside also. There's intrinsic devices that we can use to connect to the pumps on the outside and connect to the patient on the inside of the chamber also. So we can do critical care inside these environments too. Just depends on the nature of the patients themselves. When I first opened up, I talked about the fact that the full body had to be inside the environment to call it hyperbaric medicine. This is what's called a limb chamber. With a limb chamber, they pump oxygen into it, and someone put their leg or put their foot inside of this, and actually said they were getting oxygen from topical oxygen. It's basically what it boils down to. In the hyperbaric environment, it's all about breathing it into your body. In a topical environment, limb chamber is just putting oxygen over the top of a wound of some of that nature, and they said they get dissolved oxygen into those areas. Now, when I was in the Air Force years ago, we had a huge multiplex chamber. We actually treat 22 patients at a time in it. But at the same time, we were using some of these devices just to see if they actually really worked. There's some anecdotal, again, because we didn't do double-blind studies or anything like that, but we did see some type of healing did occur, but we don't know if we effectively made that healing take place, though. Any questions? So I've talked about the product, hyperbaric oxygen, how it works, what the benefits are, who can benefit from it, the different diagnoses that we treat too. Right now, we're going to walk through a couple of items that we just started treating recently, probably within the past 7 or 8 years. I'll give you guys a quick shot of that. Central retinal arterial artery occlusion. We treat those types of patients all the time. We have the Eye Foundation just right across the street from our department. We get patients in that have what they consider sudden blindness. And one doctor explained it's like having a stroke to the eye. And we get those patients, we put them in the hyperbaric chamber, and we see amazing results. People are actually blind when they go inside the chamber. We can actually get enough oxygen back into that area, where those patients can see when they come out of the chamber. We've had some good success with that. Not all the patients have benefited from it, but we have had good success with the number of patients that have come through in our relationship while being inside the hyperbaric chamber. Hypospadias grafts for kids. We've treated probably about 7 of these cases. And this tissue is just very sensitive. It's very hard to heal because of the location. Is at the base of the scrotum where the urethra opens up as opposed to at the head of the penis. And these kids have to have surgery, sometimes multiple surgeries to try to close that up. We've seen some great benefits using that surgery procedure and using the hyperbaric medicine to help with those grafts, to help those grafts heal up. We've had quite a few success with very small kids, 4, 5, and 6-year-old kids that we've had in the hyperbaric environment. So idiopathic sudden sensorineural hearing loss, sudden hearing loss. We've been treating these cases for probably about 8 years now. And we've seen some success. We can't say we know the method that's going to make all of the patients benefit from it. We don't know if it's a time factor. We don't know if it's how deep we put them in the chamber or how shallow we put them in the chamber. We've had some successes and we've had some misses on these types of cases, but the fact of the matter is we have had some benefits with that. Any questions?